greater than the surge in death rates even in coronavirus-ravaged countries like Spain. It is clear that Ecuador has been hard hit, with bodies abandoned on sidewalks and stacking up in malls. But the government has acknowledged that with testing scarce and medical resources overwhelmed, its tally was much too low. In Ecuador, from February 29th to today, 5 May 2020, there have been 31,881 confirmed cases of COVID-19, with 1,569 deaths. We now know that Ecuador's increased deaths during the outbreak are 15 times the official coronavirus toll. It is time for us to ask why. We are joined live by Ecuador's President and the Minister of Health, who is going to help shed some light on the situation and allow us to understand how the situation came to be so bad in Ecuador. Over to you.
Okay.
Good job, Gabby.
Okay, thank you. Okay, we are now joined live by the President and the Minister of Health. So, Mr. President, we would like to ask you, what went wrong and what were your mistakes in Ecuador?
Well, Rosa, first of all, I want to say hi to all the nation. And, well, many things go wrong, we can say. But it's not time to point at people and blame. It was a clear mistake to allow those football games during the first few days. And I think we can agree that it was a mismanagement. There was some kind of mismanagement by former members of my administration. However, we are now really working towards progress and things are starting to change and get better.
Okay, and Mr. President, can you explain why you went to the IMF and how are you dealing with the backlash of this action in your country?
Well, Rosa, as you may know, there's loads of fake news going around, and it's not true that the IMF is ruling our country. That is not true. We are making the decisions by ourselves, and thanks to the IMF funds that we got last year, we are able to face this crisis as good as we are doing now.
Okay, and then Mrs. Minister of Health, can you please tell the country what is your plan as our new Minister of Health since you have recently stepped in?
Yeah, but my Wi-Fi is not so good, sorry.
It's okay, we can hear you.
Can you hear me?
Yes.
Yeah, we can hear you.
Yeah. Okay, thank you. What's your question, Rosa?
What is your plan now that you are the country's new Minister of Health, and how are you going to make a difference?
My plan? Yeah, like my former colleague was resigned. It's really an accident for me. What can I do? I think we cut down our public investment to our health service. So kind of we are lacking of medical staff from 2019. So we maybe need to recruit back our medical staff. Now some of our medical staff also fall into ill. So yeah, we need more hand to help at this point. And also our Cuban data was sent back to Cuban. So yeah, we need like ask for international help as well. And another plan, I think as Minister of Health we are blamed for asking for more money, but actually we really need money more because even though we have the budget for 2020, but it's very hard for us because all the budget we already have planned. So we need ask for some money for our testing kit because now we need 2 million testing kit, but we only can bought like 200,000 kits, and they are still on the way. But we need to track and test the patients.
If you allow me, Rosa, I want to say that our Minister of Health has our fully economical support, and whatever she needs is going to be provided. Absolutely. I want the people of Ecuador to be safe and sure that we are working towards it. You are not alone in this.
Okay, thank you for that, Mr. President. So before we wrap up, can you please tell us what is happening as of today? How is Ecuador going to be moving forward?
Yes, actually we have developed this system. We call it the semáforo, which means a street light system in which each city is going to receive a color code, and according to the color they receive, the restrictions that are going to be placed on that city. Once we determine which color each city has, each city council will be in charge of carrying on the different measures. And we fully trust in all of our municipal governments. So if you get a red light, that means that isolation still stands for your region. A yellow light means that we go back to distance and more time and more days available to go to markets and streets, because here in Ecuador we have this system that depending on your car plate when you can go out, and if you get green light means that you don't have any corona cases and that life can go back to normal.
Okay, thank you. So everyone knows that the local residents have been fearful of contamination and outraged by the bodies that are building up in the streets. Is there anything the health minister would like to add to put people's minds at ease?
Yeah, I think we will work hard for collecting the truck, the cooler, and the refrigerator as well. Because for that contamination, but we will make sure like everybody have a safe resting place.
Okay, thank you for joining us. More at 8 p.m. Goodbye.
Thank you, Rosa.
Thank you.
Can I add something?
Sure.
Yes, the country wants to know.
Yeah, thank you. Before we finish, I think I just talked with our president. We have a program will cover the basic needs of our population because a lot of our population they're working in formal job, live day to day. So if we ask them to stay home. That means they have nothing to eat. So if you are living in the green color and you have the things want to donate and help people who live in the red color room, you can dial this phone number. So we will help you to transfer the food and the basic need to the resident in the red color room. Thank you very much.
Okay,
Thank
thank
you.
you and goodbye.
I finish.
Thank you.
Bye.
Bye-bye.
Bye. Good point.
Excellent.
That was so good.
That was superb. Thank you, all three of you. Wonderful. Okay, let's go on, all right, because we have to watch our time. We're now going to turn to speakers from the WHO, and they are Tevin, Talia, and Kayla, and they're going to respond to the questions, where are we now, and where do we go from here? You're on.
Okay, great.
Talia or Kayla, do one of you want to share your screen?
Yeah, I can do it.
Thank you.
Hold on. Sorry. Okay. Hold on. Is it working?
Yeah.
Yeah. Mhm.
Okay, cool.
Okay, so we'll begin. So we as the World Health Organization wanted to give a report on where we are now in terms of the response to the coronavirus and where we are headed from here. All right, so the coronavirus as of now has spread to every country and every territory around the globe. We are seeing over 3.7 million cases and have seen 256,000 deaths. We're working with all countries and territories to determine the specific needs of each country, and we are supporting and prioritizing the support to countries that have weak healthcare systems and significant gaps in their preparedness capacity for technical and operational implementation. Many countries in Africa, Sub-Saharan Africa, Latin America, and South Asia do not have such capacity and equipment to prepare for mass outbreaks and to handle such outbreaks. So therefore, these countries will receive the priority in PPE testing and as much WHO support as possible.
Okay, so talking about the PPE, the testing, and the supplies. So for the month of May, we have initiated the purchase of 4 million PCR tests and determined the distribution and allocation of the tests to 135 countries. We've also secured contracts with Chinese and Malaysian manufacturing facilities. Sorry, 1 second. To increase the volume of PPE production. We continue to strongly advocate for the urgent need to increase the production of these life-saving supplies to strengthen the response capacity of member states confronting the COVID-19 pandemic. And we've also launched a supply portal that you can find online on our website, and it displays PPE diagnostics and clinical management equipment. And countries can request the supplies that they need through the supply portal. And then talking about surveillance. Sorry, 1 second. Talking about surveillance, effective surveillance continues to be a key pillar in the response against COVID-19. So the objectives of surveillance include 1, monitoring trends in COVID-19 at national and global levels. 2, rapidly detecting new cases in countries where the virus is not circulating and monitoring cases in countries where the virus has started to circulate. 3, providing epidemiological information to conduct risk assessments at the national, regional, and global level. And 4, providing epidemiological information to guide preparedness and response measures. So to go a little more into this, countries with higher rates of imported cases or local transmission will focus on rapid detection of imported cases, comprehensive rapid contact tracing, and case identification. And countries with sustained community transmission will emphasize monitoring the geographical spread of the virus, transmission intensity, disease trends, characterization of virological features, and the assessment of impacts on healthcare services. And there's been a few different ways that they've been doing surveillance, getting their reports. So national authorities may either use case-based reporting or aggregate reporting, and countries experiencing different transmission patterns may consider using combinations of both case-based and aggregate reporting. And the decision to use case-based or aggregate reporting should be based on the capacity of health authorities and the number of cases. National authorities may move from case-based to aggregate reporting as the number of cases either increase and then back to case-based as the number of cases decreases. Robust COVID-19 surveillance data are essential to calibrate appropriate and proportionate public health measures.
You're on mute.
Whoops, sorry. As coronavirus spreads around the world, countries are faced with different decisions when it comes to public health and social measures. So decisions to tighten or loosen or even reinstitute public health and social measures, which I'll just refer to as PHSM, should be based on scientific evidence and real-world experience. Governments and policymakers should also take into account economic factors, security-related factors, human rights, food security, and public sentiment. Individual measures should be sustained. This means that symptomatic people should continue to wear medical masks, ill individuals should be isolated and treated, and hygiene measures should continue to be followed. So although it is unknown how the pandemic will continue to evolve, we imagine 3 possible outcomes. First is the complete interruption of human-to-human transmission. The second is reoccurring epidemic waves. They could be large or small. And the third is a continuous low-level transmission. Based on the current evidence, the most plausible scenario may involve recurring epidemic waves interspersed with periods of low-level transmission. So the adjusting of public health and social measures, including large-scale movement restrictions, needs to be minimized need to minimize the risk of a resurgence in COVID-19 cases. So we need to ensure that systems are in place to identify and break chains of transmission through detecting, testing, isolating, and treating all cases. We recommend that cases are isolated either in special wards, in health facilities, in ad hoc COVID-19 facilities, or at home if they have adequate support. So PHSM in the workplace, as many countries are trying to get their citizens back to work, we have some recommendations that countries should consider regarding the workplace. The main recommendation is establishing preventative measures in the workplace. So this involves promoting and enabling standard COVID-19 prevention measures such as physical distancing, hand washing, etiquette, and potentially thermal monitoring. Teleworking, staggered shifts, and other practices should also be encouraged to reduce overcrowding in the workplace.
Okay, so communication to the public is a vital role in the response to COVID-19. The public needs to be enabled, and this will be critical to implementing PHSM, as well as contributing to mitigating the social and economic impact of certain measures that are being put into place. For example, community food supply chains. With every epidemic, there is an infodemic, meaning that there's a surge of information that may or not be correct, which leads to intensified panic. So this infodemic should be managed at every stage of our response. It's completely vital to provide the right information at the right time to the right people through trusted channels so that this infodemic does not get out of control. For instance, utilizing channels like community leaders, family doctors, and social influencers will help in this endeavor. And information should be specific and explain the situation, the interventions that are being put into place, and the response plan, and indicate how long these measures will take place. So this communication is essential both for compliance with the public health measures that are put into place and also for developing adaptive social measures. So the World Health Organization is putting a huge emphasis on vulnerable nations, and they recognize the deleterious effects that COVID-19, the secondary effects that it's having on the economy and food insecurity in many regions of the world. So far, we expect that there will be 195 million jobs lost, and we expect to see 40 to 60 million more people living in extreme poverty due to this virus. Additionally, there are an estimated 135 million people now facing crisis levels of hunger, while another 130 million are on the edge of starvation. So WHO and its partners will completely focus their efforts to support these nations in an effort to mitigate these catastrophic effects that coronavirus is bringing. In addition, the UN has a global framework that will provide a strategy for this urgent socioeconomic response.
The end.
And that is it.
Excellent, thank you. Thank you. We have time for 2 quick questions. Anybody? Okay, good. Let's move on. Then we're going to go to the Israel team, who are Katie, Maya, and Nicole. Are you ready?
Yes, I will share my screen. One second. Can everyone see it? This is my first time sharing a screen.
Yeah.
Okay. Okay, so this is the current update for the situation in Israel. And we'll talk about the current cases and then the regulations and the things that Israel's doing going forward. So, like I just said, these are the 3 things we're going to go over. And so, starting with the current cases, in Israel, there have been a total of 16,314 cases. Right now, there are 5,586 cases, well, as of yesterday. And there have been 238 deaths. So the death rate is 2%, which is relatively low compared to other countries. And you can see very, very clearly in this curve of active cases, right where the peak was and how Israel has really done a good job and just very clearly has gotten over that peak and has started to go down. And that is the main reason that a lot of the restrictions have been lifted and the regulations have changed, which Nicole will speak about. But it's just really cool to finally see this this curve going, as we've been talking about for so long and hoping that this would happen. Okay, so this is Nicole.
Okay, so I'm going to start speaking. Recently, the ministry has launched new guidelines, but briefly summary of what was going on these previous days. So on the 19th of April, the ministry approved a list of different types of business whose reopening was allowed under the purple barge normative. So for example, sporting related activities or some shops could be open. And when people have to do sport activities, the distance of 500 meters from the place of residence has to be enforced. So people could be outside their place of residence 500 meters, not more than that. So another industries as manufacturing and services could return to workplace with 30% of the workplace or up to 10 employees at the same time, whichever was higher. And business with the purple seal can employ more of the workforce. So compliance with the purple seal was by this regulation. Then on the 25th of April, they decided to approve the opening of several more business. They were able to open stores under specific norm regulations. For example, some restaurants could open only for takeaway, and all the stores that weren't on shopping malls could open under a declaration to a local authority that they will meet the required conditions. Every customer, for example, before entering into the shop, must be checked for symptoms and fever, and the people who was working in the place should ask them if they were having cough or some symptoms related to coronavirus or whatever. And on the 4th of May, 2 days ago, the government has approved a series of relief measures to allow the resumption of economic activities. These regulations cancel restrictions on going out of the house, except for the same places and activities that remain banned under this regulation. Next slide. Maya, next slide.
Yeah, sorry.
Thank you. So since 4th of May, we have additional business and activities as libraries, for example, or all kind of non-medical bodily treatments, alternative medicines, malls, etc. As hotel guests, hotels or guest houses too, natural reserves. We are going to see following in another slides. So another point of these new measures, for example, related to prayer services, the restrictions on holding prayer services of only 500 meters from home or work was being revoked, and no more limit of 100 meters from going out from your residences. So now you can go outside not only for doing sport activities, but you can go for a walk more than 100 and more than 500 meters. So following slide. Despite all these new measures, of course, the Ministry of Health calls upon the public to continue abiding by the rules as wearing masks, of maintaining the hygiene, or maintaining this physical distancing. Another slide, next slide, please. So this is from the webpage of the Ministry of Health. When they launched these new guidelines on the 4th of May, they say that this is not only for this week, but it's like steps to follow. So the first stage is this one. Malls will be open on the 7th of May. Gatherings up to 20 people in open spaces are allowed. Now it's allowed to visit first related family, like grandparents or brothers, sisters, whatever. As I told you, abolition of 100 meters limit is now not it's not anymore like that. Guest houses and hotels are allowed, but it's forbidden to be in shared areas. It's not allowed to have common areas. Competitive sports and water sports are allowed only for individuals. Tourists and natural reserves are open, and education is approved in accordance of the previous outline. The previous outline, it's about the government decision of children from the 1st, 2nd, and 3rd grade will be studied 5 days a week for 5 hours a day in groups of 17 students, and then they allow to the students from the 11th and the 12th grade to attend to school too, to prepare the matriculation exam from university. Next slide. So the following steps, if everything continues as well as they suppose it's going to be, on the 10th of May, they are going to allow gatherings up to 50 people in open spaces and the returning of kindergartens and daycare centers. On the 17th of May, they are going to allow contactless sport activities and the reopening of some museums and art places. On the 31st of May, playgrounds and informal education will be allowed, and further educations will be checked to join to school. Gatherings up to 100 people will be allowed, and restaurants maybe will open. They have to check how the numbers are going to be in that day. Competitive sports will be allowed too, and but without crowds. So people are not going to be allowed to attend to see that competitive sports. And finally, in the week of the 14th of June, they are planning to allow partial civil aviation, theater, and cinema, and then are going to reevaluate higher education as, for example, our master program or university. Now.
Okay, so based on all of those, that whole plan for the new regulations and the timeline of when all those things would happen, they're kind of contingent on these 3 things that the government has stated pretty clearly. So number 1, so basically if any of these 3 things happen, then we go back inside, go back to quarantine and a lockdown. So number one is that they must have less than 100 patients a day in areas outside of the central outbreak zone. So cities that have seen a high spike, that's one thing, but if we start to see more than 100 patients outside of those areas. Number two is that the virus must not double within 10 days. So right now, I'm pretty sure it's doubling at the current rate we're at. I think it's like every 31 days, the number of cases would double. So if that goes down to 10 days, then that's an issue. And then the third thing is if there are more than 250 critical cases at one time. So I'm think if any of these one things happen, then everything is rolled back again and we go inside for longer quarantines.
Okay, so I'll talk about the medical innovations in Israel. It's actually really cool, a lot of them. I'll stick to like the ones that we found the most interesting. So the fingerprint will be basically something that the Ministry for the Defense Research and Development is working on that would identify a unique vocal fingerprint of the virus carriers, and based on voice samples from the confirmed patients, they will take information from that and also have a control group. And this can help monitor the recovery of the COVID patients. There's also a rapid diagnostic kit that now can detect the infection with saliva samples, and then you can get the results within 50 minutes. The test before was about a few days you had to wait for the results. Also, a company called Genix is working with hospitals in Israel, China, and Italy to determine whether genetic mutations may lessen or worsen the infection. And the company intends to create a database that can help predict the severity of each of the patient's case. Then we have something called Vocal Zoom, which would be like they would set up sensors in hospitals or mass transit hubs, which would be non-invasive to the skin, but it would help them determine more cases in like a bigger area. You can go to the next slide, Maya. Okay, so now I'll be talking a little bit about the treatments and possible vaccines. So the Israel Institute of Biological Research is now working towards an antibody-based treatment using plasma from recovered patients. Then we also have a polyclonal immunoglobulin treatment. This is meant only for patients who are already severely ill. So they would use their purified blood and use it to study for the next cases. In terms of the possible vaccines, there is a vaccine that is being reformulated currently in the Miguel Galilei Research Institute. And they said that animal trials will start this week, and it'll be an oral vaccine. Also, TransAlgae, which is a company, opened investment to support development of an oral algae-based vaccine, which would be in pill form. And the last thing, which I found really cool, is that this company, RX Health, is providing equipment for current quarantine patients, and they basically deliver like headsets, and they use a bunch of psychotherapy methods through these virtual reality headsets, which includes like stress and anxiety treatments and cognitive and physical exercises, also support groups. And you can also actually speak with a healthcare provider through this equipment. And I have a really cool website that I can send a link to, which is where we gathered all of these cool innovations that Israel is working on. That's it.
Okay, we have, first of all, thank you very much. Let's, right, if we can go back to the gallery so we see everybody.
Does anyone know how to stop sharing your screen?
I do.
There should be an option, which says stop.
All the way on top.
I think at the top, right at the top.
Top center of your whole desktop. Oh,
There
there
you
you
go.
go.
Good. Okay, we have time for one question, and then I have a question for Manfred coming up. But anybody have a question for the team here? Okay, Manfred, I have a question to pose to you.
Before that, I want to ask them quickly, because I think we have to, they're the ones who presented.
Okay, all right.
Quick question, and it's a big question, and we'll develop it later. The virus is not going to go away. Unlikely. So it's going to be with us for whatever. So the fact that we're preventing getting people infected is very, very limited impact, and we really don't know what the herd immunity is, but it may well be 70, 80%. For measles, as you know, it's 97%. So we're guessing. So what can we do to live with this in the future? We're not going to be able to keep doing these lockdowns and quarantine and so on. There must be a plan. And I'll throw out an idea to you. Do you believe that we actually just going to get used to the fact that there is another cause of death that some people will die of, and we'll pretty much go back to doing our own thing, and some people will die? I mean, that's a kind of a harsh reality kind of question. Do you think that's a possibility? Do you think we can get used to this?
No, I don't think so. Just because it is an infectious disease, and if we look at other infectious diseases, society hasn't been okay with that. We've developed vaccines, medications to reduce transmission and prevent the spread of it. If it was like a non-communicable disease, then yes, I think we would live with it, but it's not, so.
Okay,
Yeah,
we'll talk about it. Sorry, with somebody else.
No, sorry, continue, Manfred.
No, I'm listening to you guys. I don't have an answer.
Something similar as Stevin, that maybe, yes, we are going to get used, but in the long term, before that, we are going to use all the resources we have to avoid dying of this infectious disease. Maybe if it was a non-communicable one, maybe we can accept that reality more easily, but the fact that it's like an infectious and we have possible vaccines or possible treatments, I think we are going to exhaust all our possibilities before accepting our destiny or something like that.
Because, you know, I just made the thing, Gabby is here. In South Africa, something like 20% of the population are infected with HIV. And up to not long ago, there was really no treatment. And that was accepted as a leading cause of death. And people lived with it. I'm not telling you that they were happy about it, but they didn't stop anything. There were a lot of recommendations, but there were no laws really. You know, they didn't prevent people from having sex with more than one partner or whatever, or having unprotected. There was no law, which is obviously virtually impossible to enforce anyway. But what I'm saying is that people did tend to almost just accept it as a way of a part of your life. Maybe. I'm not saying this is a fact. I'm just thinking aloud, basically. Anyone here could have a different view, and that would be quite legitimate. Yeah. Richard, you wanted to ask something.
Well, yeah, Manfred, I was going to ask you to tell us as we look at the guidelines in Israel, how, I mean, we all know that you've been on the big committee that has really helped to do that. And can you explain to us, not literally your role, but how these guidelines get developed? What does that committee do, and how does it work? Because ultimately in their careers, many of them are going to end up being on committees like this and dealing with stuff. So can you just take a minute and tell us, do you understand what I'm asking?
I'll tell it very quickly because we'll develop this in a discussion, so I'm not going to take 2 minutes. Imagine yourselves facing a situation as a physician, I'm just giving, and a patient comes in with an infection, or what seems to be a severe infection, and you basically don't know what it is, and you can't get a diagnosis, and nobody's able to identify what the cause is. The general approach under these circumstances is you do what is called, you just throw everything at it. You try whatever you can. So you really do, you overdo it. And sometimes in a sense, I see Omar agreeing with me. Maybe we kill the patient as well. I mean, that was what happened previously. If you went back to the 100 or 200 years, they did everything. They bled the patient. They gave them toxic chemicals. They did everything. And most of the time, they killed the patient. But that was because you didn't really have anything else. So what you do is you basically, here you don't do that, but you might give 3 antibiotics, 4 antibiotics, more oxygen, more this and so on. And then patient dies. So for the next patient, you try something else. And basically, that's what sometimes happens at the beginning of these episodes. So in the beginning, it's very much a learning curve. And in a sense, you almost have to say, I hope I'm not infected at the beginning of the learning, because that's when they're learning on me. So gradually, you start to learn. And that's basically what we do in these committees. We say, well, what's happening? We, at first, just lock down. Keep everybody apart, put on masks, wash your hands, do this, without really knowing how much of that helps. But we're just trying to put everything. And then, okay, so now we reach a stage where we think we've succeeded, but we don't know exactly what succeeded. So now let's start relaxing. So we're saying, okay, you may say, well, let the kids go back to school. But they'll say, well, maybe that's what was helping us to prevent the spread. Let's rather let people first go to work or whatever. So you really are doing it, and then you use obviously comparisons with other conditions, with other diseases, and you use logic. So you say, we're now starting to understand how and you've seen it. You now start to understand what the R0 is, you now start to understand how it spreads, you understand the efficacy, some of the treatment mechanism, as you heard. Giving a lot of oxygen is probably not the best thing for most of them. So now they're giving less oxygen. Because I'll give you just one comment and then we can stop and go on. They were seeing patients now with this disease, basically when your oxygen saturations, drops below 95, 90%, that you have serious oxygenation problems. So they were having people coming in with 80%. And 80% was, people are very serious. That's a risk critical because you just got to force, and they were forcing oxygen. These are the people who were immediately being put on ventilators. Even though they weren't showing any distress, they were breathing on themselves by themselves. They weren't showing evidence of distress. But according to the measurements, they should be in distress. Now there's a much more liberal approach because when you put a person on a ventilator, there are other problems. So now they are putting people less on ventilators when they see that level and judging other parameters. So they change. So I would guess that the case fatality, the people who are dying now out of the cases, it's going to drop. And it's going to drop not because we found some miracle cure, but because we're learning better how to treat these patients. That doesn't solve all the problems. I'm just saying, but I'm saying it's a gradual learning curve. So that's pretty much what's happening with these. So we're going to watch these restrictions stop. And basically, I think you pointed out, the main indicator will be if the critical cases who need intensive care goes above a certain level, we'll probably institute regulations, basically, because otherwise the health services can't cope with it. So that's really, You know, it's as simple as that almost.
Okay, good, good. Well, thank you. And let's go on. We'll do Kenya. Then I think we'll take a 10-minute break.
Can I make a question first?
Yeah.
Manfred, is there any like trust information on how long is the immunity after getting the virus?
So far, we think, as we spoke in vaccines, we think that like most viral diseases, there is an element of temporary immunity, and it depends which one. But there's some. You have to be very careful because people will say, well, if for influenza, it keeps changing. I'm not talking, there's no change in the virus, by the way. The virus is pretty stable, fortunately. So at the moment, there are there are changes, you know, you can identify it genetically, but they haven't, what we're talking about is that the antigen that's causing the disease is very stable at the moment. So we could, even though it's part of a family. So basically, once we know that it's stable, then we think that our immune response we know that people develop antibodies, and we know that it's operating, by the way, you remember in vaccine, it's a virus which both the T cells and the B cells are operating. So it's actually, both the T and B cells are actually acting against this virus. So there's an element that not just on the memory side, but actually on the destroying the virus, basically. So you're operating both systems. So if you have serum antibodies, and you can identify some of your T cell operatives, you'll say, well, this person is probably immune, but we don't know for how long. We're a bit early. So we'll probably see declines in these antibodies, but they may still be effective. So that's still something that we're basically learning at the moment.
Okay, good. Thank you. Let's turn to our Kenya report.
Can you see the screen?
Yes.
Yep.
Okay, great. So hi, everyone. So to start off, just want to share a little bit of context regarding Kenya. So I'm going to mention 5 things quickly. The first, as most of you are probably aware, is that quite a large part of the population in Kenya is poor or near the poverty line. And also a lot of people in Kenya are working in the informal sector, which is usually characterized with low and or irregular pay. So that means that there's a high vulnerability to loss of income in the population. As many of you probably also know, 10 million Kenyans out of 50 million live in informal settlements or slums. What that means is difficult to maintain social distance because they're very crowded spaces and people are living in small houses for many people. And there's also a lack of access to many services, including water. Also important is that Kenya hosts 500,000 refugees that are mostly located in 2 refugee camps. If you can see in the map, these are these little blue dots here and here. While there haven't been any cases there so far, it would be areas where infection spread would be especially difficult to manage. So it's an area of concern. 4th point is that Kenya has a context overall of police brutality. It's not something specific to COVID, but of the past years. And this is being exacerbated during the crisis. There have been at least 12 people killed in the enforcement of curfew and 400 arrests, and also people are afraid of the police. The last points, just to highlight, is that the Kenyan population, as you can see in the pyramid, is quite young. Most people are young. There's been a lot of discussion on why we've seen less cases of COVID-19 in Africa. One of the discussed points is maybe because of the younger population. It's more complex than that. It's not just that, but just to mention that one element.
All right, so this is just a brief case overview. So right now there's, as of, I think yesterday there was 535 with just added 45 confirmed yesterday. Right now there are 24 deaths and a total of 182 that have recovered. I just want to kind of point out in this graph, so Kenya itself received kind of a shipment of medical supplies back in late March, and so that's when they were able to start actually testing. I believe it included about 20,000 kits, and then they received another shipment in about mid-April. So that's where we're kind of seeing, as they get more ability to test, we're starting to see an increase in the number of cases being shown. However, a big issue is still getting those medical supplies out to the rural areas. So if you go to the next slide, we can kind of see where there's an isolation of where the cases are located, and that's primarily because of testing capabilities, which Umar will speak about later. We can see that primarily most of them are in Nairobi and Mombasa, which are going to be the more highly densely populated city centers of the country. And as you can see, there's only been 25,000 tested so far, and Kenya has an overall population of 50 million. So there's this big disparity of who is actually being tested. And maybe once those capabilities do come around, we might see an actual increase. So next slide. So what they kind of have going on right now, currently they have all borders of neighboring countries closed, except for like maybe cargo vehicles. And they also have restricted most international flights. So people that are coming in, they do have to go under a 2-week quarantine. However, you have to pay for your own accommodation. So I guess what you have or what you're able to pay, it depends on where you're going to be staying. They have quarantine centers. Some are pretty high class, I suppose, and then others are not so much. They also have instituted a nighttime curfew between 19 and 5 local time. So as Alix mentioned, there has been this growing fear amongst the people of the police. And that's partly due also, there's been like corruption building to the directive to suspend courts. So it has become like a money-making scheme. Police arrest and charge heavy fines as they can't be challenged in the court due to this. So people are a little freaked out about that. And also a lot of these killings and I guess abuse have been during the nighttime curfew time. Also, major counties have restricted travel in and out. This includes places like Nairobi and Mombasa. And at these borders, they have set up police checkpoints where they are enforcing, making sure that drivers have been tested and that they are negative to enable them to move in and out of counties. Schools, pubs, entertainment venues, churches, and mosques have all been shut down. And schools have taken kind of a directive. Public schooling has moved to YouTube videos. They are aired on radio stations as well as TV. And then private schools have moved toward more integrated learning, kind of like what we do with Zoom. People are also required to wear face masks in public, and they face arrest for not doing so. Currently, there isn't much directive for safe disposal. So people are kind of just throwing their mask on the ground. And because people fear arrest, a lot of people who can't afford to buy these medical supplies, they're actually picking up like used masks off the ground to avoid arrest. So it's causing a big problem there as well. As far as working, employers have been encouraged to allow staff to work from home. And then all places of work are required to have a hand washing area with soap and water. And small businesses have been encouraged to introduce cashless transactions. Next slide.
As Kayla and Michael mentioned before, Kenya has a shortage of kits, swabs, lab reagents, and also trained human resources. Most of the people are volunteers, and they're actually helping out, and they don't really have the proper training for it. But yes, Kenya did lose a couple of critical weeks in the middle when it didn't really have any of the equipment. But compared to its neighboring countries like Uganda and Ethiopia, they were doing 2,500 and 1,500 tests per day, while Kenya was doing just 300 per day. But now, at the end of April, China and a couple more other countries sent out 200,000 testing and sampling tubes. along with other equipment. So with these, the government started mass testing in high priority areas in Nairobi and Mombasa. But the problem is a lot of people are apprehensive on going and getting tested because of many reasons, actually. One of the reasons is like Michael mentioned before, that they have to pay for the quarantine. The second reason is if they test positive, then they have to also pay for the test. The third reason is their neighbors or their friends saying that the testing was very painful. The fourth reason is they're afraid that if they go out in the public, they themselves would catch the coronavirus, would catch COVID-19. So they are requesting the government to come and test them in their own houses. So because of all these reasons, there's been very low testing in Kenya. So the government is actually encouraging people to come and get tested. And on Friday, when they did a test in one of the high priority area, 1,095 people volunteered to take part, and out of which 24 turned out to be positive in just one single area. So imagine all those areas that they're not even testing this prevalence of COVID-19. So from May 2nd to May 4th, in these 2 days, 1,300 tests against 5,000 people were done, especially in the area of Nairobi and Mombasa. Coming to treatment, there's no treatment as of now. Patients are being helped to cope with any symptoms they exhibit, such as fever or sore throat. There hasn't really been very severe cases. So Kenya has started clinical trials for remdesivir, hydroxychloroquine, and lopinavir. Next slide. Now we go see a little bit of how COVID-19 is impacting Kenya economically. So Kenya recently received a $50 million loan from the World Bank to support the country's emergency response. So this is not for stimulus, this is not as a stimulus package, but this is mostly for medical related interventions like buying medical equipment, ventilators, sampling tubes, etc. The stimulus plan has also been announced by the government late March. So a few of the measures were, the tax measures were reduction of income tax from 30 to 25% and a reduction of VAT. So other than the VAT option, nothing else was declared for the informal sector. With their source of daily wage vanishing, reducing the VAT won't really have an impact because they don't even have to buy any food. So forget about paying any of the taxes. 10 billion Kenyan shillings were given to the elderly, were planned to give to the elderly, orphans, and other vulnerable members of the society. There's been a temporary suspension of loans for micro, small, and mini enterprises. Along with this, Kenya has a public debt of $60 billion. So there's already a lot of burden on Kenya. Along with this, tourism, agriculture, and manufacturing industry, the three of the main industries of Kenya have also taken a toll because of COVID-19 as they depend on the European market. And also the governor of the Central Bank of Kenya says that the economic growth is going to drop from 2020, going to drop 6.2% to 3.4% in 2020. There was a survey done in 5 slums with 2,000 people, out of which 4 out of 5 people have seen some kind of loss of income, either partial or total, as a result of COVID-19, and more than 60% have skipped meals. Alex, next slide.
So recommendations, the Africa Center for Disease Control and Prevention, so the Africa CDC, released a report yesterday trying to give advice to the different African countries on how to go forward with the situation. They highlighted that countries must now find a balance between reducing transmission while preventing social and economic disruption, which of course is valid for all countries, but as we saw, is particularly acute for a lower income country. So part of their recommendations included focusing on public health, specifically the capacity to detect, test, isolate, and care for confirmed cases. And we also add protecting health workers, including those lay health workers that are helping educate the population so not just people that are working in hospitals. Another recommendation is to scale up social assistance programs to protect the most vulnerable. So Umar mentioned, so some of this is already in place. Just to give you a sense of scale though, some 100,000 vulnerable families were identified and they're receiving 1,000 shillings every week. That's €8 per week per family. Of course, purchasing power parity is very different in Kenya than in Israel, but still the minimum wage for an uneducated person is €13 per week. And that's €8. So, you know, it's good, but people are still going to have a hard time. Continuing public education campaigns is of course important. One, to dispel misinformation. There's a lot of talk going on about whether it's the painful tests that Umar mentioned, or also information saying that certain people are not vulnerable to get infected. And also communication focused on prevention measures and accessing social protection. So not just the communication shouldn't just be about health related things, but also about how to access social protection. The Africa CDC report also emphasizes the importance of monitoring data to see what the local conditions and needs are following measures, and to take data-driven decisions. We also wanted to add the importance of supporting firms and small businesses, the proper disposal of personal protective equipment to avoid the kind of situation that Mike was talking about, where people are picking up used masks. Amnesty International and a group of other NGOs have suggested that there should be they should remove a ban on rooftop rainwater harvesting that's currently in place in Nairobi, which could help access to water. They've also requested basically to make water and electricity free. That might be more difficult financially, but removing that ban doesn't take any financial resources from the government. And maintaining vigilance and preparations in high-risk areas like the refugee camps that we mentioned earlier. The last point to mention is not so much for Kenya, but for countries that can help support Kenya. So for them to, where they can, continue their funding efforts, honor funding commitments, whether that's directly to Kenya or to institutions that are helping countries like Kenya, like the WHO. So that's it. Komesha Corona is, what is it again, Umar? Let's beat Corona?
It's Stop Corona in Swahili.
Oh, Stop Corona.
Stop Corona. Okay, excellent, good. Are there, you're going to stop the screen, right? Screen sharing. And are there questions for them? One question I have, do you trust the data that you're seeing from them?
We talked a lot about the lack of testing, both because of there are not enough tests, and then once there were tests that people weren't coming in for testing. And we know that in such a resource constrained country, even countries that are rich were not sure about accuracy of data. So how can we be sure in such constraints?
Yeah. Other questions? Great presentation, thank you.
Excellent.
Thank you. Okay, let's take a 10-minute break. Is that okay? And we will reconvene. I have 12 minutes after the hour, so it's now 13 after. Let's say 25. Okay, 5:25 for you. All right. Okay, everybody. See you soon.
Okay.